Okay, we'll just get started. Um, so we're starting off, the next unit is gonna be on strokes and TIAs for today. You have your certification to do at home for the NIHSS. Um, so this is pretty good for the neuro exam we just had on Friday. There was one give back, I haven't done it yet. So there'll be one, it's on the ALS versus the anterior horn destruction one. So that one will be a give back. Everything else was fine. So that will happen at some point. So today we're going to go over strokes. The big thing with strokes is, again, vascular supply. So we have to go back to our anatomy, know all the vasculature going up to the brain, because it's going to play a role in how you diagnose these strokes. We're going to start with very, very gross strokes, meaning like anterior, like the carotid stroke, so infarction of the carotid occlusion, what happens upstream from all that, and then you get to your more minor strokes, what happens there. We'll talk about TIAs, which is an impending stroke. It's just a mini stroke, it only happens about 24 hours. And then we'll go on to atrial fibrillation again, bring that back because obviously the strokes, they go hand in hand together. And then we'll go over hemorrhagic strokes, which is when they start bleeding out. So your subarachnoids, epidural hemorrhages, and subdural hemorrhages and all that fun stuff. So for brain attack, same thing as like heart attacks. When they have a stroke though, they're gonna have trouble walking, weakness on one side of the body, maybe some visual problems, trouble speaking. Some of you may have heard the FAST mnemonic. This is just a joke, it's not the real one. There's another one that's the real one. So this is the real one, okay? So FAST, so facial weakness, arm weakness, speech problems, and then time is brain, which is the important part for strokes. That's why I harped on in the beginning with the history and physical part with regards to last known well. This is very, very important when it comes to strokes, which means when was the last time the patient was seen normal without any signs or symptoms of a stroke? Let's say you wake up in the morning and you have signs of a stroke. When was the last time someone saw you normal? And if it was yesterday at 5 p.m., then yesterday at 5 p.m. was the last known well. You have to figure that out because the only treatment we have for strokes is TPA, that tissue plasminogen activator. You can't give it if there are certain criteria, which we're going to go through later on. One of them is 3 hours after the event. If you're after 3 hours, you can't give that medicine. So you have to know when was the last time they were normal. If they were normal before they went to bed and they woke up abnormal, it's still 3 hours, it's 12 hours. Whenever they went to bed at 9, they woke up at 10 this morning, that's 12 hours, 13 hours, whatever. So last known normal is very, very important. So definitions, cerebral infarction, just like a myocardial infarction, death of brain tissue due to impaired perfusion, could be like an MI, myocardial infarction, or global hypoperfusion, meaning the brain is just not getting any blood, the pressure goes down. What does our body do when the pressure in the brain goes down? Pass out. Okay, we just pass out so that we normalize gravity and hopefully blood can go. So that's what hypoperfusion could be. Vascular occlusion is the big one, and there are two examples, thrombotic and embolic. What is thrombotic? The clot, is it stationary or is it moving? Stationary. The thrombus is the stationary clot. The emboli is what? The part that breaks off and goes somewhere else. So atrial fibrillation, for example, the thrombus is where? Left atrial appendage is where the thrombus is. The emboli break off, and then they go and cause the strokes. So thrombotic or embolic are the two most common for vascular occlusions. Talking about cerebral ischemia is that reversible condition. So remember, ischemia means it can either become infarcted or you can resupply perfusion and the ischemia goes away. So it's reversible depending on time. Are you doing it in a fast enough manner to preserve that brain tissue? So a TIA, transient ischemic attack, is a brief episode. It only lasts a little bit. It goes away. And they're caused by a focal brain or retinal ischemia, meaning there is an actual vessel we can find that is where the ischemic event is happening, and that's why they're having their symptoms, and once it goes away, perfusion is restored, and whatever happened goes away. Retinal ischemia, if they have like sudden monocular blindness, maybe due to an intermittent ischemia of the retinal artery. Once that blockage goes away, perfusion comes back and your vision comes back. Usually neurodeficits last about an hour, usually complete resolvement within 24 hours. No evidence of any acute infarct, so all your imaging is going to be fine. Not going to show anything. The problem with TIAs is the last bit. It's an indication of an impending stroke. It means they already have the stage set for occlusions. They already have some probably thrombus accumulation in the vessels. Same reasons with myocardial infarctions. Those vessels are very small to begin with. All those platelets aggregate, occlude the vessel, no blood can get through. Same thing happens here. Like we learned in clin path, you guys learn in cardio with these vasculopaths. We look at signs and symptoms depending on wherever they are in the body. Same thing we do with hypertension. Some people with vascular problems may have it in their legs and they get intermittent claudication. If they have it in the cardiac system, then they have chest pain. If it's in the brain, then they have TIAs and strokes. Remember, it all just depends on where these things start accumulating. So if they have a TIA, now you gotta start worrying about prevention of that major stroke to happen. So definition, just a stroke by itself is the syndrome of acute neurodeficits due to cerebral infarction, due to sudden focal interruption of blood flow that causes neurodeficits. So when it comes to this neuro stuff, whenever you see something focal, it means you can point to an area that's where the problem is coming from. When people come in with like migraines, they're not going to have any focal neural deficits. They're not going to say, I have weakness in my right arm. No, they're going to say, I just have generalized, I feel weird, I have a headache really bad, and I have symptoms from the headache. There's nothing else neurologically wrong with them. Now, if they do develop some neural signs, weakness on one side of the body, numbness, strength deficits, or whatever, then when we get to the headache section, we'll see those patients, you gotta start scanning them for something wrong. But if they don't have any focal things, that's what we're talking about. Now, there's two types of stroke, ischemic and hemorrhagic strokes. Ischemic is the most common at 87% of strokes are ischemic, so it is due to vascular occlusion, thrombotic or embolic. Both of those are ischemic strokes. They occlude blood supply. Whether it's a emboli or a thrombus, it's the same thing. You're occluding blood flow. Hemorrhagic are your 13% left over. These are the ruptured arteries, and blood is oozing out into the brain space. But the end result from both of those is lack of blood supply, right? Whether it's ischemic, you're not getting it to the area, or you burst a vessel and blood is oozing out before it can get to your target place, both are going to have ischemia. So again, stroke subtypes, your ischemic can be thrombotic or embolic, and your hemorrhagic strokes can be intracerebral within the brain or subarachnoid. And then here's just another way of like looking at the classification of different types of strokes. Your hemorrhagic, again, intracerebral or subarachnoid, but then your ischemic can be thrombosis, large artery extracranial, so your carotid artery occlusion. You guys do your Bruey checks for that. You're looking for these large artery occlusions, small penetrating artery disease. We'll see that with lacunar infarcts. We get embolic strokes, and they usually are the source of heart, and then we also have systemic hypotension. So we mentioned before that global hypoperfusion. usually when there's some blockage to the whole brain from being choked and stuff like that. So epidemiology of strokes, 5th most common cause of death in the United States. That may have moved down because of COVID. They don't release the results that often. So, most common disabling neuro disorder. The most common type of stroke is an ischemic thrombotic stroke. That's the most common one. Almost 800,000 strokes a year. 20% of stroke patients will die within 30 days due to all those comorbidities and problems that come along with the rehabilitation of it. Mortality for survivors, nearly 20% each year. 90% of survivors of a stroke will have some residual deficits. So one-sided weakness versus the other, maybe some speech deficits, something, but they may have some residual deficits. 30% of survivors are permanently incapacitated. That's usually a result of a lot of the hemorrhagic strokes. The hemorrhagic strokes have a worse prognosis than the ischemic ones because you're bleeding out, and again, time is brain. How fast can you get that artery plugged up and closed? So the outcome, cerebral ischemia, depends on whether the process is global, meaning hypotension to the entire brain, or is it focal just to one area based on territory? What artery is feeding that area? Remember, when we go to the arteries, we have to go back to the homunculus and our territories and what parts of those pre-central gyrus, the motor cortex, is supplied by what arteries. So with the focal ischemia, they get that central zone of cell death, and then remember that area of that zone of ischemia around it. What neurotransmitter is going crazy in that surrounding tissue around the area of ischemia? Glutamate, right? And glutamate is what? Excitatory. So all those areas around it are also potentially being in that reversible stage. That's why we give drugs, those glutamate antagonists, to kind of turn off and preserve that brain tissue around the area of ischemia. Infarction occurs where the thrombus is. So embolic material may occlude larger cerebral vessels. And obviously, just like we learned in ClinPath, hypertension is the main culprit when it comes to strokes, which is why, again, with your patients, getting them to treat their blood pressure, take their medications for their blood pressure is very, very big. Especially worrisome in smaller vessels. So when we talk about our lacunar, and I had it right there. So lacunar infarcts are mainly due to high blood pressure. Cerebral edema also happens after infarction. You get both intracellular and extracellular edema. If you look at this top picture, you can see kind of how swollen that brain is compared to normal images. You don't have the area around nice and all the little, usually you see a little bit more ridges in that area. Now it's all gone because of the brain swelling. And look at this real picture. You can see how swollen that brain tissue looks from this cerebral edema. So it reaches maximum 5 days after onset of the infarct. So that's why you have to watch them for a few days afterwards. Most deaths, well, later on they get necrosis with some contraction. Let's look at this picture right here. What do you notice about this area right here that I'm highlighting? What does it look compared to the rest of the tissue? Darker or lighter? Looks a little dark. Looks a little lighter to me. Okay. Looks dark. My eyes are bad. It does look dark. Does this look darker compared to that area? Yeah, ours is darker. Okay. Yeah, it's darker. Okay. Anyway, so why would it be darker in that area? What did they have? No. What does blood show up on white? So if it's darker in this area, why is it darker? What's not there? No blood. They had a stroke. Okay? That's why you look at these things, like the color. Okay? If it's lighter or darker, there's no blood there. It's nothing's going to glow. Therefore, they have a stroke because it's right there. Most deaths occur 1 week after massive cerebral infarction due to cerebral edema. So We don't like cerebral edema. That's why a lot of these patients have to go to the ICU for different types of management to get that intracranial pressure down. We don't like that very much. Risk factors for stroke. Obviously, hypertension is going to be number one. Age, the older you are, that's why that CHADS VAS score, what's the A?
65.
Well, it's age, right? Because we have to incorporate age, but 65, you're right. Smoking, diabetes, other risk factor, AFib is there. Preceding TIAs, 25% of patients who present to the ED with a TIA will have some adverse event in 90 days post. So a quarter of the patients with TIAs, that's why we treat any TIA, they go right into that prevention protocol, high cholesterol management, sugar management, blood pressure management, get them off smoking if they're smoking, exercise if they're not exercising, those lifestyle modifications immediately, because you don't want to have that real stroke later on. These are diagnoses that will mimic a stroke. So when they come in, they may have some right-sided weakness or some speech problems. You have to rule out a lot of things before you can just say, yes, they're having a stroke. Migraines that will mimic a stroke, but the migraine onset is a little more gradual, slower onset, whereas a stroke is a little more rapid. Because remember, this is a vascular event. It's going to be more rapid onset. Seizures may also mimic a stroke, but seizures don't present with weakness usually. They will have some post-ictal confusion, though, with a seizure. Seizures, they will have some muscle soreness afterwards from the tonic activity, but not weakness. Syncope may also mimic a stroke. Transient global amnesia, they just have some memory disturbance with no other neural problems. Peripheral nerve disorders, remember we talked about like Saturday night palsy, you lay on your arm, and then you wake up in the morning, your arm is weak and you have pins and needles. Oh my God, I'm having a stroke, my arm is dead. No, once blood supply comes back, you'll feel better. But again, people will show up in the ED for weird things. Intracranial masses, okay? Any elderly person coming in with a headache, new onset seizure, assume they got a mass in the head. Something's going on that's causing these things to happen. Neuroses, panic, anxiety. So with behavioral health, you're learning all the different things now. How many of you are self-diagnosing? And metabolic disorders. This is an important one here. Hypoglycemia. Extremes. They'll show up with their will think they're having a stroke because their glucose is so low. They're not. You just treat the glucose and they'll be okay. They're not having a stroke. So these are some differentials when it comes to someone coming in with stroke-like symptoms. Obviously, the killer in this case is the stroke. The commons are, syncope and those things. Characteristics. If they had an embolus, so that piece broke off, traveled to an area, got lodged in a smaller artery, caused an issue, then went away, that's abrupt onset followed by rapid improvement. So these are your TIAs. TIAs are mostly going to be these emboli that break off. That's why it's a sign of impending stroke. Because if they already have a thrombus somewhere, and if more pieces keep breaking off, if a bigger piece breaks off that maybe can't get dissolved in time, now you cause a stroke. Thrombus, abrupt onset with progression to maximal deficit over minutes to hours, onset during sleep, or a stepwise progression. So they'll be fine, they'll have a deficit, and then this is their new baseline. They'll be like that for a while. They have another issue. They go down here, they'll be on that for a while. And that is your stepwise progression in diseases. If you suspect they have an intracerebral bleed, onset will be associated with severe headache and alterations in consciousness. Why do you think they have a severe headache? All the pressure from what? Blood that is leaking into a space that it shouldn't be there. All the blood should be confined in all your arteries, but if you have a hemorrhagic artery that broke, all that blood that should be in the arteries are now leaking into all the space around the brain, causing pressure. So we'll get to that later on. Improvement versus deterioration. Again, if it's a embolus, they usually have rapid improvement, thrombus, gradual improvement over days to a few weeks. If it's an intracerebral hemorrhage, rapid deterioration over a period of a few hours. So the timing matters. So again, going back to your HPIs, progression of disease, what happened first, then what happened, what was the timing of these things, how long ago did it happen? So that's all very important stuff to get in your HPI. Okay, so our circulation, just to remind you guys, the anterior circulation along the top, middle is that big area in the lateral, and just posterior is obviously in the back. Another way of looking at all of the perfusions at different angles to show what parts of the brain are perfused by what arteries. So let's go over our strokes. So we're going to talk about strokes as defined by anterior circulation or posterior circulation strokes. The anterior circulation of the brain, we're going to focus on the carotids, anterior cerebral artery, and the middle cerebral arteries. All three of those are potential sites for occlusion and strokes in the anterior circulation. The posterior circulation is our vertebrobasilar. Remember, we have our vertebral arteries that also work its way up, and we have our posterior cerebral artery. So there are 5 arteries we're going to look at with potential strokes, and then we'll look at the deficits that they're going to have based off of those issues. So the first one are the anterior circulation, carotids, anterior and middle cerebral artery. So the anterior cerebral circulation, internal carotid artery. We know that plaques like to start at the bifurcations. Those are the high areas of shear stress. So they get damaged. When areas get damaged, remember all the processes that have to go to repair that. That's where streaks start to form. Those foam cells get in there, start to proliferate, oxidize, get fluffy, and we get a plaque formation. That's where our fatty streaks happen at those bifurcations. So we get an infarct from embolization at the bifurcation or complete occlusion of that internal carotid artery. That's why you have to listen for bruits first before you palpate the carotid artery. Okay, these things the bruit is turbulent flow across the vessel. A murmur is turbulent flow across the valve. They're the same things. It's just listening to sound that's turbulent. So symptoms of an internal carotid artery: transient monocular blindness, amaurosis fugax. Why? Your carotid artery feeds your eye on the same side. So if you occlude the carotid, you're occluding everything up from that. So knowing your anatomy, knowing the carotid is the big one, if you occlude that, everything upstream is going to have problems as well. So they may get that. They may get slurred speech and aphasia if the dominant hemisphere is affected. So how do we know dominant hemisphere? What do we ask? What hand do you write with? So if they are ambidextrous, they still will have a main hand that they will use. So find out whatever main hand they use, and that will be their dominant hand. And then you do the cross from there. They may also get some contralateral sensory or motor deficits as well. Again, a bigger territory of occlusion that you're causing here. So, cortical function loss. Again, dominant hemisphere, they're going to have problems with language. The non-dominant hemisphere. So if the carotid artery is occluding their non-dominant hemisphere, then they will get some neglect and confusion. So that hemispatial neglect where they just won't do things on certain sides of their bodies. They may get hemiparesis. What is hemiparesis? Half of the body. Is it the top half, the side, left or right, top and bottom? What is it? Left and right. Does that make sense? Why you would be hemiparesis? Remember, what does the carotid artery feed into? What two arteries? Anterior cerebral artery, which feed the legs, and the middle cerebral artery, which feeds arms and face. So if I include the carotid, I'm including also the middle cerebral and the anterior cerebral, which gives me hemiparesis on one side of the body. Because I'm including so far down, I'm getting both. Hemisensory loss, lethargy, and stupor may be present as well. So this is with carotid artery occlusion. It's a bigger territory that you're causing. So don't confuse this dominant and non-dominant. All we're saying is, if I'm right-handed, my left side of my brain is dominant. If I have carotid artery occlusion on the left feeds the brain on my left, I'm going to have problems with language. If the occlusion is on my right side, because I'm right-hand dominant, this is my non-dominant side of my brain, I may have signs of neglect or confusion. So it all is based off of what the patient has for their dominant hand. That will tell you, is this a dominant side of their brain? So it clues you in, oh, they're coming in with language problems. Okay, maybe that's they're right-handed. Okay, maybe a left-sided stroke because they're having language problems on the dominant sphere of their brain. We haven't done any imaging yet, but already you can start figuring out where I think the problem is. So some characteristics of a carotid artery syndrome: ipsilateral monocular vision loss. So they're going to lose vision on the same side as the problem. That amaurosis fugax, that shade comes down over one eye. I will say, after having eye problems, a lot of those things that they tell you are not true. I've had 2 retinal detachments, and there's no curtain coming down over my eye for both of them. None of that was ever true. Episodic contralateral arm, leg problems. Understand why it's contralateral? The lesion is above the crossover. We're in the brain now. So it's going to cross over, nothing on the other side. Slurred speech, some aphasia, ipsilateral headache of vascular type. So they're going to have a headache on the same side of the occlusion. You may have a bruit noted. And you may see some changes in the retina on that side. Hemorrhages, exudates, splinter hemorrhages, those things in the eye as well. Now moving on to anterior cerebral artery occlusion, maybe from an emboli, but also a subarachnoid hemorrhage as well. Symptoms: lower limb weakness. Why? Anterior cerebral artery feeds the legs of that premotor cortex. May have some sensory loss and apraxia, inability to complete a motor task. Okay? Do range of motion with me, do the dance, and you tell them to follow you, and they can't do certain things. So contralateral paralysis of the leg more than the arm, because we're dealing with the anterior circulation, which is all the legs. Contralateral sensory loss, more so in the legs than the arms. Apraxic gait, contralateral grasp reflex, and sucking reflex. These grasp reflex and sucking reflex are called primitive reflexes. These are like babies do this. And as we get older and elderly, and you guys learn this in geriatrics, they get to a certain point later in life, certain mental or neurological diseases, they revert back to primitive reflexes. So you'll see them doing this all the time because they're going back to those primitive reflexes. And the grasping reflex with babies, if you put your finger in their hand, they're going to grab it. It's a reflex. They don't love you any more than anyone else. Just a reflex. And this last one is called abulia. Spontaneity is lost and lack of concern that something is wrong. I just don't care. Like, something's wrong. The house is on fire, like that meme, the house is on fire and the guy's just sitting there like everything's fine. That's what abulia is. Like, I don't care anymore. That's what it is. Middle cerebral artery. Main stem occlusion results in severe disability. So the middle cerebral artery is the really bad one to have affected by a stroke. Contralateral motor and sensory deficit. Again, the lesion is still above the crossover, so it's contralateral. Homonymous hemianopsia, global aphasia if the dominant hemisphere is affected. Anytime we mention dominant hemisphere, those are, make sure you understand those ones as far as how it relates to symptoms that they may have. So cortical function loss, the dominant hemisphere, aphasia, agraphia, acalcula, alexia, all things they can't do anymore. They can't recognize objects. They can't have problem with calculations and stuff like that. If the non-dominant middle cerebral artery is affected, again, we get neglect, apraxia, and confusion again. So that non-dominant hemisphere, same symptoms. They may also have a gaze deviation towards the infarcted hemisphere. So if they have an infarct on the right, their eyes may gaze towards the right as well. Hemiparesis, arm is going to be weaker than the leg. The middle cerebral artery is the arm, upper body, and face. Leg may be circumdated outward, may have some hemisensory loss and some hemianopsia, some vision problems as well. Any questions on anterior circulation strokes? You got carotid artery, middle, and anterior cerebral artery. So just know the symptoms that happen with each one. Now we're moving on to our posterior circulation strokes. So with posterior cerebral artery, we know our posterior lobe is our occipital lobe. That's where our visual cortex is. So we're going to start having some visual problems. So hemianopsia in the visual cortex, some memory deficits, unformed visual hallucinations. So if you suspect someone has a stroke, but they're hallucinating things, like, oh, I can see something that's not there. They'd have no history of any schizophrenia. Maybe it's a posterior artery stroke because they're having visual hallucinations, and that's all the visual area that's being perfused. They may also have thalamic syndrome, sensory loss, athetosis. Why do you get sensory problems with the thalamus? All sensory relays go through the thalamus. So if you have thalamic syndrome, you're going to have sensory problems because they all go through it, and some athetosis. If it affects the brain stem, remember we don't like brain stem infarcts, that's where all of our vital processes are controlled. They may get Weber syndrome midbrain, so ipsilateral cranial nerve 3 palsy, contralateral hemiplegia or hemiparesis, paralysis of eye movements, so nothing happens, they won't be able to track anything. So these are some brainstem effects with these posterior cerebral artery occlusions. Vertebro-basilar artery occlusion. So remember the vertebral arteries we have in the posterior part that also feed the brain. Binocular visual disturbances. They're going to have both eyes are going to have a problem. Whereas with the carotids, it's only one eye, which is the eye that's affected on that side. But with a vertebro-basilar artery occlusion, you may have bilateral vision problems. Vertigo, tinnitus, nausea, vomiting, having some vestibulocochlear issues, some balance problems. Sudden loss of postural tone on all 4 extremities. They're called drop attacks with no loss of consciousness. The arms just don't move anymore. They stop. Slurred speech, ataxia, numbness around lips or face. May have a cranial neuropathy, some eye problems, we talked about that. Paralysis, sensory loss, and they may have a coma as well. This last one is a little bit of a phenomenon called subclavian steal syndrome. And I'll just explain it with the picture, easier that way. So we have our carotids coming up, and they branch off into our vertebral arteries, and then we have our subclavian artery going out, right? Everyone following? So what happens is these arteries do communicate. The vertebral and the carotids, eventually they start communicating up and they get up into the brain to allow for backups of blood flow in the case of a stroke. Now, if we have an occlusion that occludes our subclavian artery, will any blood get to our arm? Anything get to our left arm? Not really. So what happens is the blood that goes up the carotid comes back down the vertebral artery to feed the subclavian artery. That's why it's called subclavian steal syndrome. We're stealing the blood from the vertebral, or from the carotid, to feed the vertebral, which allows you to feed your left arm. Why would this give you a mimic of a stroke? What's not going up to the brain anymore as much? Blood, because we're pulling it back down to feed our left arm, left subclavian. So subclavian steal mimics a stroke because less blood going to the brain, because we're stealing it to feed our left arm. So we get the steno-occlusive disease in the subclavian artery. So we get decreased perfusion to the ipsilateral arm and hand. So left arm and hand don't get as much perfusion. Subclavian artery will branch distally to the obstruction with collateral pathways to maintain upper limb perfusion. If the level of stenosis proximal to the vertebral artery, reversal of flow in the vertebral artery may occur, and we're going to steal that blood from the posterior circulation. When the upper limb is exercised, blood is diverted away from the brain to the arm. So with activity, they may fatigue and get tired fast and dizzy, lightheaded potentially, some vision problems because they have this steal phenomenon. You just do a scan, you'll see the clotting, you just remove the clot, and then they're fine. So that's subclavian steal syndrome. Symptoms, pre-syncope, syncope, because again, less blood is going to the brain. It's going to act like a global hypoperfusion on the side that's affected, mainly the left side. So they have some global hyperperfusion on that side, causing that syncope, maybe some neurodeficits. Blood pressure differential between the arms. So when you do your bilateral blood pressures, the left arm is going to be weaker, less and less of a value because there's less blood there because of the steal going on, the occlusion going on. Arm claudication, again, if there's no blood going to the arm, it's going to fatigue out and get tired faster. Treatment, endovascular stenting, just get rid of the clot, stent the artery, and you treated it and you're fine. Small vessel disease, this is known as your lacunar infarcts. Arterial hypertension is the major risk for this one. These are not usually preceded by TIAs. These are very, very, very small artery problems. They evolve slowly, usually pure motor hemiplegia. Wherever these little infarcts occur is where you're going to have your deficits. So they start having deficits in their left arm. We know that that's part of the brain that they had their deficits in. May have some dysarthria, ataxic hemiparesis. Dementia is here as well. It can lead to multi-infarct dementia. So when we get to cognition disorders later on, we get to dementia, we're going to bring this back again later on, but multi-infarct dementia. You're causing dementia by just obliterating the tissue, and you get your deficits that way. It's a stepwise progression of symptoms with this one. Because every time you have a new series of lacunar infarcts, you have a new deficit, and then you're fine for a while. Then you have a new infarct, you get another stepwise progression, and it kind of goes from there. So basically, you can see little areas right there that get obliterated due to high pressure. Just those high pressure in those little arterioles and capillaries are not made for it, and they just start bursting, and they cause the deficits to occur. So lacunar infarcts, hypertension, small mini infarcts, stepwise progression may lead to multi-infarct dementia. Okay, how do you assess a patient with a stroke? So it is a medical emergency. So ensure medical stability, hemodynamics, make sure blood pressure, respirations are good, ABCs. They may have some increased intracranial pressure. So they may have decreased respiratory drive, which happens with increased intracranial pressure. If you decrease respiratory drive, it causes hypoventilation. Hypoventilation leads to increased CO2 retention. Of course, they're not able to blow it off as more. So our CO2 is building up in our blood, which leads to further cerebral vasodilation, which further elevates our intracranial pressure. So you have to watch out for these things. That's why managing intracranial pressure is so important. You can start a vicious cycle where it's just going to get worse. And obviously, blood pressure management as well. Labs, CBC, SED rate, CMP, glucose. Why is glucose so important? It's one of your differentials, hypoglycemia or severe hyper. PT, PTT. Why is that important to get? What's the only treatment for a stroke that we have? TPA, which is a clot-busting drug. So they're going to become very, very anticoagulated. We don't want to make sure they're already anticoagulated and further make it worse. So we have to know their PT-INR status, PTT status as well. Hypercoagulable workup for a young patient. Young patients don't have strokes, and if they do, why are they having a stroke? What's the underlying cause for it? Why did this patient have a stroke? And reverse any conditions that are contributing to the problem. So if it is that severe hypoglycemia, treat it, and then see how they perk up from that. EKG and monitoring, obviously you gotta get their heart rate and rhythm. If normal, can exclude most causes for cardiogenic causes for a stroke. As long as there's no AFib on the monitor, no other heart rhythms that can lead to other issues, you can kind of rule that out. If they have AF, go through your thing you did with cardiology again. Is this new onset, paroxysmal, is it chronic? Are they on any anticoagulation? Which one are they on? There's a bunch like Xarelto, Pradaxa. Those have no monitoring for them. Whereas if you're on Coumadin, you get INRs. So find out what are they taking. If they're on Coumadin, what was the last INR, which hopefully you would have in your workup for that patient. Diagnostic studies. So you see the difference now? What kind of stroke would that be? What is that going to be? Hemorrhagic, you see? This is bleeding into the space, bright white, lack due to occlusion, no perfusion, the image will be darker. So stat non-contrast CT of the head. Why, if you suspect a stroke, why do you have to do a non-contrast CT first? Not do the pressure. Well, if you want to see where the fluid is, you kind of need contrast, though. Because that's you label the blood, you see where the blood goes. But do we know when someone comes in, if I come in with my right side is down, do I know what type of stroke that I'm having right now by looking at me? And what are the two types of strokes I can have? Or hemorrhagic. Can I give contrast to a patient who's got a hemorrhagic stroke? What's going to happen to all that dye? It's going to leak out and go all over the brain and all these problems. So you have to do non-contrast first to make sure they don't have a hemorrhagic stroke, because you will see it. But you have to make sure they're not having a hemorrhagic stroke first. So it's always non-contrast stat CT first. If you don't see anything, then you can do an MRI, which is more sensitive for this type of problem. What's the problem with MRIs though? They take too long. And what do we need to know about strokes? It's all time is brain. So CTs are faster and we can go from there. MRI, sooner with MRI than CT, but again, it's a time issue and we have to make sure that we have time to give them TPA and all those fun things. History and physical, again, last known normal. Rule out those disorders that can mimic a stroke. Physical exam, assess for bruits, your peripheral pulses, cardiac murmurs, irregular rhythm. Remember, you're looking for a vascular path. You're looking for vascular disease elsewhere in the body because If they have it in the cerebral arteries, they're going to have it elsewhere probably. So check your carotids, your peripheral pulses, and ruling out AFib. Vascular screening, you could do a carotid Doppler for your carotid artery stenosis. If you suspect any intracranial internal carotid artery, you can do a transcranial Doppler ultrasound. That'll look at those arteries to see, make sure they're all intact. You can do an MRA, may detect stenosis of these large cerebral arteries. And conventional angiography is still the gold standard, which is basically like a cardiac catheterization. Under fluoroscopy in the brain, you inject the dye and you see where all the vessels go, and you'll see where the clots are, the blockages. Same exact thing. Very good for this arterial malformations, arterial venous malformation, the AVM, where there's a communicating vessel between the artery and the vein. They're very weak and they're prone to bursting. Your transthoracic and TEEs, remember TEEs are very good at looking at thrombus in the atria. So that's when you want to do a TEE, not the TTE. Okay, let's take a break. Come back at, give you 10 minutes. Come back at 10:55 or 9:55. Oh, 10:55. Okay, so we've gone through history and physical, what diagnostic tests we want to do, where we think things are going. We diagnose them with a stroke. Now, how do we manage them when they have the stroke? So antithrombotic therapy with ischemic stroke. Notice we didn't say just strokes in general. This is only for ischemic strokes. So TPA is the only approved therapy for strokes. So what is plasminogen? Let's go back to blood and physiology. Breaks down the clots. So tissue plasminogen activator, you guys didn't miss anything, don't worry. You didn't miss anything.
Okay. Good, thank you.
So we're giving you plasminogen to bust that clot up to resume perfusion of the blood in those areas. Ideally, 3 hours of the event. So remember 3 hours. 3 hours is the cutoff. Patient who present in time to be candidates for treatment within TPA must be evaluated by a physician within 10 minutes. Undergo CT scan within 25 minutes of arrival, and have that CT interpreted within 20 minutes of test completion. So how much time are we at right now if we add all that up together? 55 minutes. So we're already cutting into that 3 hours because of that window. So the goal is to give TPA within 60 minutes of arrival to the ED if they are a candidate for TPA. They have to be a candidate for it. If they're presenting with stroke onset and they're not a candidate for TPA, you give them aspirin once the exclusion of a hemorrhagic stroke is done. So you've excluded a hemorrhagic stroke. I assume they have an ischemic stroke, but they are not within the window for TPA. So at that point, we give them aspirin. So this is an important slide because this is the exclusion, the contraindications of when do you not give TPA. If they had significant head trauma or a prior stroke within 3 months, you can't give TPA. If they have symptoms that suggest a subarachnoid hemorrhage, what is the line for a subarachnoid hemorrhage? What would the patient usually say? Worst headache of their life, thunderclap headache, sudden onset, massive headache. Then you would think they have a hemorrhage. So if they're hemorrhaging, you don't give them TPA because then they'll bleed out and die. If they have an arterial puncture at a non-compressible site in the previous 7 days. Okay. So if they had an A line put in their arm, brachial, that's compressible. I can put something around it to compress it. But if they had an injury somewhere else that's non-compressible, they may not clot as well. Giving TPA will cause more bleeding. History of prior intracranial hemorrhage. Again, anything with hemorrhage in the word, don't give TPA because you suspect they're bleeding out. Intracranial neoplasm, AVM or aneurysm, any surgeries, BP greater than 185 over 110. That's another big one. Any active bleeding. Some of these things you don't have to memorize, just common sense. Would I give someone TPA if they have active bleeding internally? No, I don't need to memorize that. Just common sense, don't give it. So don't waste your brain on that one. Acute bleeding, diathesis, including but not limited to, where am I cut off there? Okay, I'll find out what happened there. Platelet count less than 100,000, which means that when they stop this TPA, they're gonna have problems with clotting afterwards. Any heparin within 48 hours, can't give them further anticoagulation after that. If they have a current use of anticoagulant greater than 1.7. So 1.7 INR and above, you can't give TPA. Now, what can you give to lower the INR before you give TPA if you had to? Vitamin K. Remember, vitamin K will reverse the Coumadin and bring the INR down, but you have to wait for that to happen, which may take too much time, depending on how high the INR is. So 1.7 above, be very careful with TPA. Any type of direct thrombin, those factor 10As, Pradaxa, Xarelto, those type of NOACs, be careful with those. Blood glucose less than 50. Why does that make sense? Hypoglycemia will also mimic a stroke. So if their glucose is already less than 50, let's treat it. Maybe they won't have the stroke symptoms anymore because they had hypoglycemia. So you don't want to give someone TPA when they don't have a stroke. It's just because they have hypoglycemia. So that's just a way to look out for that. And if the CT demonstrates multilobular infarction, so they've had multiple emboli that spread out and cause multiple locations of clotting, they don't get TPA either. So these are the absolute contraindications. These patients do not get TPA. Active surgery, recent surgeries, active internal bleeding, recent strokes, recent GI bleeds. Be careful with those things. These are the relative. So these are the ones where you weigh the risks versus the benefit. What are they going to benefit from this? Or are they not going to benefit from this? So patients may receive therapy despite one or more of these. If they have minor or quickly improving stroke symptoms, like probably a TIA, went away on its own. Pregnancy, you can't be very careful. Seizure at the onset with post-ictal residual neural impairment, so they may have had a seizure. Major surgery or trauma within 14 days. Recent GI or urinary tract bleeding within 21 days. And recent MI within 3 months. Why do you think the MI within 3 months? What are they given a lot during a MI? Anticoagulants. A lot of those, apixaban, those 3B ones, they can linger for a while. And if you give more stuff on top of that, they can bleed out easier. So be careful. You have to find out what were they given in that MI within 3 months. Also, if they were stented, they're going to be on aspirin and Plavix every day within 3 months, at least 6 months if they have a bare metal stent, just to keep that thing going. So you have to be careful. They're going to be anticoagulated already. You have to put more on top of it, find out what doses they're on and whatnot. So those are the ones with TPA. Who gets it, who doesn't get it. So that's your first kind of rule of management when they come in with a stroke. Are they in the window for TPA, which is what's the magic number? 3 hours, and then do they meet the criteria? The next thing we have to worry about is blood pressure management for these patients. Ischemic strokes cause decreased blood flow distal to the obstruction. Nothing can get past it. So we need pressure to perfuse past the occlusion and get past it. So we do need some elevated blood pressure to keep our brain perfused with this stroke going on. Blood flow in distal blood vessels is dependent on our systemic blood pressure. Maybe a chronic condition or the response to decreased cerebral perfusion with their elevated blood pressure they're having now. So the 2013 guidelines state you don't treat blood pressure acutely in a patient with an ischemic stroke unless 220 over 120. That's when you'll start treating the blood pressure. In an ischemic stroke, because with the hemorrhagic one, it's different parameters. So you need that pressure in the system to perfuse distal to the occlusion. If you drop the pressure too much, you're not going to be able to perfuse that tissue. What's going to happen to that zone of ischemia? It's going to get worse and increase. So we need that pressure there. So 220 over 120 is the magic number for an ischemic stroke. What do we give? Labetalol is the best one for this case. What are the guidelines? 15% reduction in the first day, 24 hours. Not a drastic reduction in blood pressure. If you lower it too fast, again, you're going to worsen that perfusion. We need that pressure to perfuse the brain tissue. If you don't have it, you're going to make that ischemia worse. So with an ischemic blood pressure, 220 over 120, and give labetalol, 15% over 24 hours. After the acute event is over, they've had their stroke, they're stable, they're in ICU, prophylaxis for DVT and PE. They're not going to be as mobile as they once were. They may have problems with that. Physical therapy, speech therapy, occupational therapy, speech studies. Anyone with a stroke, don't have them eat until they pass a swallow study. The swallow study gives the patient increasingly thicker fluids to swallow, and they see how much they can tolerate before they start choking and coughing. So they start with like water, and they go to like thicker liquids, and they go to honey and different things to kind of see how they can swallow. Understand that, again, of the patients who survive the acute period, only a little over half will regain independent function. So now you have to deal with all the patient education and patient management after the stroke. 30% will remain incapacitated and require long-term care, assisted living facilities, SNFs, rehab placements somewhere for long-term management due to the loss of function due to the stroke. TIAs, again, they resolve within 24 hours usually. Again, warning sign of an impending stroke, precede thrombotic strokes in 50 to 75% of the patients. So if they have a TIA, we got to worry about that next one. That could be the big one that either kills them or severely incapacitates them so they can't live their normal life. And difficult to identify the area because the symptoms go away. Remember, everything with the neuro, we can figure out what part of the brain depending on where their deficits are. But if they go away, the clot goes away. No matter what scan we do, we're not going to see anything because the clot's gone and they don't have any more deficits. So urgent eval if you suspect they have a TIA. Like type and location, non-contrast CT of the brain. Get a duplex ultrasound so you can detect the carotids. Transcranial Doppler to check the middle and the anterior cerebral arteries, make sure they're okay. You can get an MRI or MRA to look for stenosis. Get an ECG and your transesophageal echo, your TEE, look for clots. Hospitalization may expedite workup. So TIAs may come into the hospital and then the symptoms go away. They're here for like 24 hours and they go home. But sometimes if you keep them in the hospital, you can get all this testing done faster while they're already in the hospital rather than discharging. They have to go to an imaging center, make an appointment, all that stuff. They can just do it while they're in the hospital. So consider hospitalization for Patient with a first TIA in the first 24 to 48 hours, worsening symptoms, or with a known carotid artery stenosis, AFib, or if they have a hypercoagulable state with a TIA, get them admitted to the hospital, just keep them in and do some workup. So treatment, again, TPA technically can be used as a TIA, but we don't really use it that often because usually it's going to resolve. Antiplatelet therapy is the big one. Okay, so aspirin, 325 daily. Ticlid is a more stronger one. Antiplatelet than aspirin with preventing strokes, you can go to Ticlid. Very expensive, but again, Plavix is now generic clopidogrel, so that's cheaper for the patient. So antiplatelet therapy, you have to prevent the second stroke from happening. So antiplatelet therapy, prevent that clotting from happening. And you can also do a carotid endarterectomy. Get all the junk out of the carotid, clean it out so all the plaques are gone. Just quick review. There's an ABCD rule for TIA. Who is at risk for a stroke in the next 7 days? So remember, anytime they have a TIA, that's usually a sign of an impending stroke. So we can use this criteria to see what's their risk of having a full-on stroke in the next 7 days. Age, older than 60. Blood pressure, not well controlled. If they have high blood pressure, that's the B. You get a point for that. If they have unilateral weakness, they get 2 points extra. Speech disturbance without any weakness, they get 1 point extra for the C, for clinical factors. The duration, if it lasts longer than an hour, they get 2 points. Less than an hour, 1 point. Remember, TIAs are supposed to be transient, so they should be resolved within 24 hours. And they should also, if they start lasting minutes to hours longer than an hour, that's more of a impending sign. So scoring 7-day risk, obviously the higher the points, 6 to 7 points, you are at an 11% risk of having a stroke in a week if you have higher points. So again, ABCD rule, just remember for TIAs, I'm not going to have you calculate this on an exam. You got Medscape on your phone, pull up the calculator and you can figure it out that way. So primary and secondary prevention. Primary prevention, we want to prevent the first stroke. Secondary, we want to prevent the second one. Obviously, blood pressure reduction is very, very important. Reduce your cardiac risk factors. Aspirin, okay, anticoagulate them. If they have AFib especially, 70% risk reduction with anticoagulation for AFib. Hyperlipidemia, get the cholesterol levels under control. And if they have carotid artery stenosis, you can treat that as well. Secondary prevention, stroke survivors will average 10 outpatient visits a year. So a lot of management for these stroke patients when they get out. If they had an embolic event due to AFib, then they have to be anticoagulated. Warfarin, Xarelto, Pradaxa, any of those drugs. Non-fatal stroke reduction by about 20%. Patients treated with aspirin. So aspirin, 20% reduction, start them on aspirin. You can do carotid endarterectomy if they have symptomatic stenosis, 70% of the carotids, with high velocities, lipid lowering, and obviously smoking. So again, a lot of lifestyle modifications. You want to prevent the second stroke from happening, which potentially could kill them or severely incapacitate. 20% of all strokes are due to AFib, so watch out for AFib. You know that already. Warfarin versus aspirin. What's more effective in preventing strokes with patients with AFib? So they did studies with patients who were at least 75 years of age. Randomized controlled trial, aspirin 75 versus warfarin to maintain a warfarin between 2 and 3. Warfarin between 2 and 3 is more effective than aspirin 81 in preventing strokes. So warfarin is better. It's just a lot of problems with warfarin. If warfarin came out today, it probably won't get approved because of all the side effects, but because it's like 80 years old. It got grandfathered in along the way. The side effects, but there's nothing else. We've tried there's other drugs, but nothing works as well as warfarin, so got to keep it. Here's your CHADS-2 VAS score. You should all know this by now, right? Had it in cardio, I know that. Okay, those are all the ischemic workup management, all that stuff. Now moving on to our hemorrhagic strokes, where blood is bleeding into the intracerebral space. Again, hypertension is the most common cause for these non-traumatic hemorrhages. We'll get to other things, like in elderly people with like moving their head too fast, like in an accident. It's trauma, but it breaks all those little bridging veins and causes issues later on. Bleeding sites, common areas are the deep cerebral, lobar, pons, and cerebellar are common locations for the intracerebral hemorrhages. Subarachnoid hemorrhage, ruptured arterial aneurysm, or AVM. So those arterial venous malformations. Weakness in those vessel walls, high pressure will burst them. Bleeding causes the increased intracranial pressure and decreases blood flow, causing your loss of consciousness. Signs and symptoms: worst headache of my life, headache, neck stiffness. You get a stiff neck, just from the swelling in the subarachnoid area, stiff moves your neck. Non-focal neuroscience, nothing, you're not going to have right arm weakness. It's just going to be like loss of consciousness and they're out. Here's your AVMs. Again, these are very, very weak vessels and they're prone to rupturing. And when they rupture, they bleed out because you have the arterial high pressure side still, which is still going to push all that blood out. Very rare, 1% of the population may get it. Mostly congenital, rarely genetic. Some will experience headaches or seizures. And again, once found, treated easily with clipping. You just go in there and kind of just put metal clips on this end and clips on that end, and you cut off supply to that malformation, and it kind of goes away. Non-contrast CT first, as always, to make sure they don't have a hemorrhagic stroke. And you can see here what happens with an acute subarachnoid hemorrhage, all the bright white spots that show up from all the leaking blood. MRI will be brighter. If you have a patient with a presumed subarachnoid hemorrhage coming in, it just happens suddenly, severe headache. If the non-contrast CT is negative, but you still suspect they have subarachnoid hemorrhage, do a lumbar puncture. Okay, so high index of suspicion and a low threshold for performing a lumbar puncture, meaning I suspect they have a subarachnoid hemorrhage. I'm going to do the lumbar puncture now. I'm not going to wait for more tests. Let's just get it done and see what it does. You get what's called xanthochromia within 4 hours of the time of hemorrhage, which is basically you get red blood cells, pinkish fluid because of the bleeding. Now, blood pressure control in a hemorrhagic stroke. We talked about the ischemic stroke. What's the blood pressure goal for that one to get? When do you start treating? 220 over 120. That's when you start treating those patients. With a hemorrhagic stroke, you gotta be a little bit more careful because they're gonna be bleeding out. So you wanna reduce the pressure a little bit, but again, you can't reduce it so much because they're not gonna perfuse anything distal to that hemorrhage. So the goal for an intracerebral hemorrhage, 150 to 220, acute lowering of systolic blood pressure to 140. For those with systolic blood pressure greater than 220, you want to do a continuous IV infusion to get that systolic down to 140 over 160. So you do want to bring it down, but you don't bring it down to like 120, 110. You want to keep it around 140 so they still have some perfusion pressure going forward, but not so high that you make them bleed out from that open area. So some examples: IV nicardipine, clofidipine, labetalol is here again. So these are the good drugs to use for lowering of the blood pressure, IV management to get it down. If you suspect they have a subarachnoid hemorrhage, this goal is 160, but the optimal BP is still a little bit unclear. Labetalol is here as well. This is the key here. If it's a subarachnoid hemorrhage, avoid nitrates. What are nitrates going to do? Vasodilate. What's happened to the pressure if you vasodilate? Pressure is going to drop. We're increasing the radius, the pressure is going to drop. Therefore, that kicks out of our perfusion. We lost our perfusion, and we can't perfuse our brain. So avoid nitrates if you suspect a subarachnoid hemorrhage. So the benefit of lowering the BP may be offset by an increased risk of infarction. So we got to be careful. We're juggling some pressures here. We don't want to lower it too much, then we lose our perfusion of the brain. So we look at our cerebral perfusion pressure, which equals the mean arterial pressure minus our intracranial pressure. So what this is saying is when our cerebral perfusion pressure is reduced because of the stroke that we're having, we may need our mean arterial pressure high enough to perfuse everything, which is why we need our pressure higher. How do we get our mean arterial pressure? Just a ratio between systolic and diastolic pressures. You know that? So MAP. That's why we need to keep our pressures up. So further management. So how do we treat the elevated intracranial pressure? Keep head of the bed elevated. So gravity pulls blood down out of the brain, reducing the pressure. You can consider a medicated coma, barbiturate coma. Some people have severe hypoxia of the brain, severe heart attacks. We put them in a medical coma to kind of let everything relax. They even do cold cools where they actually will cool the body down real fast and help preserve tissue that way. Mannitol is very good at lowering intracranial pressure. Consider hyperventilation. Why would hyperventilation work? Reduce intracranial pressure. And what will happen to the CO2 in the blood? Decreases. And what will that do to our cerebral pressure if our CO2 goes down? Decreases it. So increased CO2 increases intracerebral pressure. That's why hypoventilation is bad, because it retains CO2, and further increasing intracranial pressure further makes things worse. Cerebral edema. Watch out for seizures and control the glucose for these further management of these intracerebral hemorrhages. Surgical intervention, because these people are having an open vessel, it needs to be treated. You can do surgical clipping or placement of a coil for an aneurysm. I'll show you a picture of that in a second. External ventricular drainage if risk for hydrocephalus. External ventricular drainage, basically you have a shunt. One tube is in the ventricles of your brain. The other one is usually drained into your peritoneal cavity, or it's drained into an external one. But basically you're taking off the excess CSF to reduce the pressure for that. You can ligate or embolize the AVM, open craniotomy, depending on where the bleed is. They may have to take the skull off, find the area. That's why they do those burr holes to get the blood to ooze out, find a place for it to escape. Is the patient a candidate for surgical options? So, someone comes in with a hemorrhagic stroke, the odds of survival are low as is. Yes, we want to do all life-saving measures as much as possible, but sometimes you have to look at the patient and realize, are they going to recover? Even if we do this, what's their life going to be like? What's their quality of life going to be like, even if we do this? So, grade 1, normal level of consciousness, mild symptoms. Yes, they are a candidate for surgery. Grade 3, they are a little bit confused, but they have some focal neural deficits, yes, they can have surgery. Look at the last one, grade 5, coma, decerebrate posturing. Not a candidate. Which one is the decerebrate posturing? When it's out. Remember I said that's a worse prognosis? Doing the surgery is not going to help them come back. So if they're in that type of posturing, that's a grade 5. They are not candidate for surgery. Do you have a question?
I actually do have a question, so when you said like the lumbar puncture, I know there's like increase in cranial pressure. Are we not worried about the
So what did we do at first before we do a lumbar puncture? And that will tell us everything you need to know. If they have a brain mass, herniation, anything going on, that would be the contraindication from doing a lumbar puncture. But if the CT was normal, and I suspect they have a subarachnoid hemorrhage, then I would do a lumbar puncture to see if there's any blood in there. Okay, so coiling. So if you had an aneurysm, that's our vessel. That little bump is the aneurysm. What we can do is we take with surgical wire, the neurosurgeon will come up and put wire in there and coil the wire inside the aneurysm. When that happens, that whole area is now foreign to the body. Clotting goes in there and it'll seal that area off. And now the aneurysm has been taken care of. So that's what coiling is. You just wrap a bunch of crap in there, wire, coil it inside, and eventually it'll seal itself off. The other thing is clipping. And okay, so with clipping, they just go in again. This is usually also take part of your brain off so they can actually get to this area. And they just put, again, metal clips. And it clips that area off, and that area is no longer has access to the bloodstream. So that's what clipping is. So you just clip it, the aneurysm, so it doesn't have any communicating anymore. They should be fine. So those are the two ways you can do coiling and clipping, the way that works. Mortality with intracerebral hemorrhages and subarachnoids, high level of mortality. 20% will die before they even reach the hospital. So these prognoses of these hemorrhagic strokes are very, very bad. 25% will die from hemorrhage or the complications. 20% die from rebleeding. So high mortality rate with these types of hemorrhages. And we're done. We'll do a lot more with the hematomas and hemorrhages when we get to like disorders of consciousness. And you guys are done. See you guys on Friday.